The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. This is Travis Ansel with HSG. With me is Davis Creech. You are attending today's webinar, which is Reducing Employed Physician Network Losses. Before we begin, a few housekeeping items. Within the GoToWebinar Questions tab on your control panel, you'll be able to submit questions to us during the webinar. We will do our best to tackle those as they pop up if they're relevant to the content we're covering, and we'll cover all other questions at the end of the webinar. If there are any we do not get to, we will follow up with you by email after the webinar. Today's event will be available for on-demand viewing at hsgadvisors.com by this time tomorrow. Everyone who attends today's webinar will get a link to both the video and slides within 24 hours. Moving into today's presentation, as we said, reducing employed physician network losses, and we're going to do this with a little bit of a flavor of what we're focusing on, not only in an overall employed network environment, but what we're focusing on, what we're talking to organizations about, kind of coming out of the COVID pandemic. What has it changed? How has it changed thinking about employed physician network subsidies? What are areas of focus? What are some of the questions we're getting now as an organization that predominantly works with employed physician networks across the country? So in terms of what we're covering today, the first thing we'll be covering is just our philosophy around employed physician network losses and how we see that playing out in the marketplace, especially right now, coming off of a rough couple months for health systems across the country. Two, we want to talk about our thoughts on putting your organization's subsidies in context and defining realistic targets, because for any organization that wants to undergo performance improvement or subsidy reduction, one of the major challenges we find with health systems around the country is one, understanding, putting our numbers in the right context and in the right benchmarks, and then two, figuring out what's a realistic point to move to. And we'll work through some of the frameworks that HSG has developed to help organizations get their arms around that. And then three, we want to talk about our framework for how networks should be evaluating themselves comprehensively and how you define areas of opportunity in terms of reducing network losses. And then four, we'll talk about some of the organizational capabilities needed to create change. And what you'll hear us say probably multiple times in this webinar process is having data and being able to identify areas of opportunity are great. And a lot of those opportunities can be taken advantage of administratively, as we like to say, by people in suits. But what we find working with networks around the country is the real capabilities we need are getting physicians engaged and creating the right infrastructure, the right governance structure, the right leadership structure, so that our providers are intimately engaged in helping with the management of the network. And really the things that really drive, some of the things that really drive employed physician network subsidies really require the buy-in of the providers to change. So we'll talk a little bit about that as well. So moving into our observations on physician network losses with, again, some flavor of the COVID era, put into our philosophy. A quick definition, because this definition is not consistent across, as we work across the country. The definition of losses, or if you want to be more positive, subsidies, or if you want to be really positive, investment in your employed physician network, is not consistent across all organizations. When we talk about any of these terms here, we're talking about the net financial performance of operations of employed physician practices, which includes direct expenses plus allocated health system overhead. So we're looking at the net financial performance of the practices plus allocated overhead. Where some variations of that we see some organizations, as they present their financials and look at their losses, start adding back allocations of downstream revenue from the hospital back to the practices, recognizing that, we've probably over the years we've stripped a lot of things out of the practice, and we want to be fair in our presentation of the physician network finances. One challenge we see with that is that's a very inconsistent way compared if you're trying to get actual benchmarks on your network's performance. That creates a very inconsistent methodology and tends to paint a very rosy picture, and maybe hide some of the opportunities on the revenue side from improving physician network performance. One of the things we also see is we tend to see organizations either not allocating health system overhead or under allocating health system overhead, particularly as it relates to organizations that have integrated finance and billing operations, where they're doing both hospital and practice or physician network billing. And so we tend to see that for some organizations being hard to separate, so they roll it together, and that expense hit doesn't hit the practices, which again creates a pretty rosy picture, but kind of hides some of the cost that might otherwise be allocated. So in terms of losses, subsidies, investments, this has obviously been a historical pressure point ever since employed physician networks were created. Most of those went away and then came back in the late 2000s. Some of those have existed for 20, 30, 40 years, but always has been a historical pressure point. What we're seeing in the market is through the impact of COVID on elective and routine care. March and May, we're seeing organizations that are, from a net margin perspective, 10 to 15% off budget. We're not seeing a lot of questions yet around, oh gosh, our response to this needs to be, we need to manage our subsidy. Everybody's really focused on what's our reopening plan, how do we get volumes back. But invariably, the financial pressure created by COVID over the last 6 to 8 weeks, and I would argue that is going to happen to us still through the next 3 to 6 months, because volumes are not going to bounce immediately back, is going to put health systems under additional financial pressure. And as we all know, the thing that always sticks out on hospital financial statements or health system financial statements are losses on the employed physician network. So we view this as something that will invariably put additional pressure on health systems, and this is something that anyone who has accountability for employed physician network losses, or who has accountability for a health system finances, of which a part is employed physician network losses, should be prepared to manage more aggressively over the next 12 months. We do expect that, as I mentioned a minute ago, that we do expect that a post-reopening focus will be on expenses once revenue starts flowing again. So we don't expect this to be if you're going to your June board meeting for the board to be asking questions about the employed physician network. I would term it as more of a September to December discussion, when boards and executive teams begin looking to manage margin. And the one thing we're always quick to caution organizations with, even those that are doing well or that are within benchmark, is benchmarks are what they are. They give you a directional sense of how are we doing against everyone else. But when it comes to the finances of your health system and the finances of your employed physician network, it really doesn't matter if you're within benchmark or not, if it's not within your health system's if your losses are not within your health system's financial goals or targets. So even organizations that are within benchmark probably should be preparing a plan for if we need to aggressively manage subsidy and cut 5 to 10% of subsidy out of the network or more out of the next year. I'm in the place where I'm advising our clients that we need to have that plan in our back pocket, even if we're not proactively implementing it right now, because this question is going to get asked. We have a survey we've been doing across health systems nationally, called our COVID-19 Strategic Implication Survey. One of the questions we asked was about how aggressively do you see your organization managing physician subsidies going forward? 2 quotes we got back that were from CEOs were, one, we think all organizations are going to continue to evaluate physician practices, but we're probably going to view this with more diligence going forward. 2, this is probably an opportunity to really manage our lower producing providers, to either be a little more aggressive in engaging them on let's get you productive, or this is perhaps the time in our evolution where we start managing those providers out, and sustainability becomes more than ever. And those quotes kind of fit within our thinking of where employed physician networks are going to be over the next 12 months. For anyone who's familiar with our work or our philosophy, we center our thoughts around physician network growth within our framework of physician network growth phases, which really emphasize for what's going on in the world today and what's going on in the last decade or so with employed physician networks. Where everybody's at right now or most organizations are at right now, is somewhere within this bandwidth of operational chaos and strategic focus. And to put some definitions to that, we really view the left side of our physician network growth phases curve as being how do we build our network, and basically in a rapid growth phase. This is for everyone who's on the phone who's involved with the physician network. Rapid growth phase is that period where we went from we're employing physicians because maybe maybe a handful of practices approached us, or maybe we had a few providers who needed the security of employment, to we had a handful, and now we have 80, 150, 400, and that in most markets, that growth period, whenever it happened, because it happened at different times for different markets, but in most markets, that's happened within a 3 to 5 year period, and invariably, when we move from rapid growth to operational chaos. Operational chaos its definition is we've grown bigger than our capability to manage. And one of the key characteristics of operational chaos is the network and the health system kind of getting paralyzed by the financial performance of the employed physician network and feeling like we're unable to move forward. We're unable to engage our physicians about anything other than the financial performance of the network. Every time we have a meeting, we're talking about the financial performance of the network. We're delaying recruitment decisions. We're underinvesting in staff and leadership. We're not investing in building long-term capabilities because we're feeling like we can't add one more dollar of subsidy to the network. And so that's where a lot of networks still are, but we're seeing a lot of networks that have made it past that, and have made it past that by building infrastructure, building a leadership team, getting the physicians engaged, and move to a period that we call strategic focus, which is where we're past the point of building our network and making it work, and we're figuring out how we're leveraging our network for success. So the one interesting thing about COVID, which you can see in the title of this slide, is we're really worried that networks that have moved past this inflection point are going to be moving backwards into operational chaos because, one, as we mentioned in the previous section, we think the conversation about employed physician networks is going to go backwards and going to return to we really need to aggressively manage the subsidy, and that's going to restart conversations about how quickly do we grow? How do we keep executing our current recruitment plan? Do we keep executing our geographic growth plan? What about all the staff we have that was working fine when we were fully productive? Now, if we're 80% productive for the next 6 to 9 months, do we keep those staff members? Do we need to take out some of our administrative overhead to reduce cost? And that threatens to put everyone back in operational chaos. Now, and then we layer on the things like, every organization across the country right now has basically implemented a 5 to 10 year virtual health plan in 6 weeks. And so we have infrastructure that we've temporarily built to manage that, but what does it look like when we're trying to manage that as a core competency? Have we accounted for revenue cycle changes that have occurred over the next 6 to 8 weeks and will continue to occur as we get more and more guidance from regulatory agencies around what virtual and telehealth is going to look like when everybody's doing it across the country? So we see networks moving backwards on our growth curve over the next 6 to 12 months and having to reevaluate everything they did to get out of this operational chaos phase, and basically build a plan for going forward. How are we going to get to a point of financial sustainability again? What does our management team look like? What does our org chart look like? What are the right seats? Who's in them? And how do we manage this thing going forward? Now, the good news, when we look at what we think organizations should be doing across the continuum, when we look at operational chaos, a lot of the things that we're talking about in today's webinar are the things that organizations who are in operational chaos should be doing. One, pursuing network performance improvement initiatives. Two, reevaluating the systems we've built to promote healthy revenue cycle functions and provider productivity. Three, enhancing, or I would say reevaluating and then enhancing what appropriate management infrastructure looks like for an employed physician network in the current environment and going forward with everything new that we've built. And then 4, which is, I think, starting to come onto some people's radars, between reopening and having a new surge of patients that are seeking access to care, as well as the disruption of virtual and telehealth, existing referral patterns and existing patient usage patterns that existed as recently as February 2020 are probably going to be pretty significantly disrupted when we get back up to speed over the next 2 quarters. And so having really intensive focus and building competencies and capabilities around making sure our referrals stay in network, and we would add being able to track patients across the care continuum from a claims perspective is going to be incredibly important, because relying on our patients to come back and utilize us and return to the same competitive dynamics within a market is probably unrealistic at this point. And so one of the core capabilities to getting back up to speed and getting to financial sustainability by growing revenue is going to be making sure those patients get back in our network and that we're actively tracking them to understand where they're going. So that's an overview of philosophy. So now let's talk about how, specific to each of your health systems who are on the line today, how do we put your network subsidies in context, and how do we get to a realistic target? And so to do that, we're going to talk in the context of a sample health system. And here what we have is basically just the highest level income statement possible. And this is based off of a real health system, but the numbers are obviously adjusted. So when we took their initial data, basically the way that they had designed their financial statements that they utilized to measure the financial performance of the network had performance in the 100 million revenue range, $20 million subsidy range. But as we discussed when we started this webinar, it's important to, if we're going to truly evaluate financial performance, what we have to do is adjust those financials to be consistent with benchmarks like MGMA, so that we can get a good feel for how are you actually doing compared to benchmark. And what we saw when we adjusted that is, well, actually, when we stop allocating back downstream revenue, and when we see a subsidy that's actually closer to 45 million, and when we create a projected range based upon per provider, per physician, and per work RVU benchmarks, we really see something that puts the network in a 60 to 85 million dollar range for net revenue and a 20 to 35 million dollar subsidy. So whereas they may have looked at the benchmarks and said, well, we're at 20 million, and our range might have put us, our benchmark range might have put us in that $20 million range. When we start actually building appropriate financials that give us the ability to accurately benchmark the network, we see, based upon the benchmark, that we probably have some significant financial opportunity. And so that's the first part. Is one, we need to any organization need to take a step back, look at how you're allocating both revenue and expenses to the network, and do that as close to benchmark as possible. Do that as close to the process for developing benchmarks as possible. The second thing we need to do is evaluate that subsidy on a per something basis. So here, we'll say it's important to measure revenue and cost on a per blank basis. And we like to focus on whatever metric you're incentivizing providers to achieve. And for most networks across the country, whatever we're incentivizing them to achieve is most commonly the work RVU. So for this example, we're going to use the work RVU. And so this network had approximately 1 million work RVUs in its last fiscal year. That's correct, within plus or minus 10%. And so when we start looking at the expenses, so going back a slide, we start looking at these total expenses, and we start looking at the net revenue per work RVU. We get their current subsidy, and then we start thinking, well, what happens if we're able to actually move that cost per work RVU? And what happens if we're able to move that revenue per work RVU? And what's really realistic? And this type of analysis is useful because, one, we start putting numbers into context. So this 125 dollars per work RVU. If we look at benchmarking that against MGMA, that shows us we're a relatively low expense network. We're between the 25th and 50th. We're not below the 25th, but we're a relatively low expense network. So we need to take into account that moving horizontally there's probably some opportunity, but there's not a giant opportunity. At the same time, we're here in the range of net revenue per work RVU. We're at $75, which puts us closer to the 25th, which probably indicates there's some opportunity. There's probably a little more opportunity to move down the curve on revenue per work RVU. The reason we like this graphic is because we get organizations that come to us and say, well, we just need to cut, our subsidy is ridiculous. We need to cut 40, 50% out of the network. That's how we are going to get it sustainable. So we start talking about moving from this current state to, well, let's increase our revenue per work RVU from 75 to 87, and let's cut our cost per work RVU from 125 to 113. That gets really unrealistic with most of the measures organizations are willing to take to manage their subsidy. We'll get into what I mean by that in a little bit. But so that becomes one of the challenges. So one, we need to understand what our revenue and cost per click is. And again, most networks use work RVU. Some organizations encounter, some organizations use visit. But whatever we're truly is most directly, whatever measure of volume is most directly tied to what you're incentivizing providers through your compensation plan, that's how we need to be evaluating our subsidy and our ability to move our subsidy. And so as we get into evaluating how we move, the first thing we want to do is make sure we have a comprehensive assessment of how can we change these numbers? So how can we move revenue and expense management? The second is how realistic are those? So we talked about that. And then the third is, are the health system's expectations realistic? So all three of those things incredibly important as we're evaluating how far we can move and where we want to get to, and do those things match up? Because frequently, and I think I'm betting most everybody on the phones had this experience, what we tell the physician, say we have a physician leadership council, what we tell our physicians we want to get to financially, what we're capable of doing, and what we're willing to do are often three disconnected points. And so matching those three things up and defining a target that is realistic and that people are bought into, and that we feel like we can get to, is incredibly important to any performance improvement initiative. Otherwise, we're going to be pulling together three different sets of data that are never going to match up, and having some level of performance improvement might be great, but we're not hitting targets, so everyone feels like they failed. The physicians feel like they're being targeted, and everyone comes out of the exercise feeling worse about themselves and the network. So going back to how we evaluate revenue generation and expense management, our framework that we utilize and recommend clients utilize is really about doing a comprehensive assessment of both revenue and expense management. And the reason we built this is we found a lot of networks were when we talked about subsidy management, got very focused on, we need to manage the expense half of the P&L, and we really need to manage physician comp. And if you're in the position of your biggest problem within your network is physician comp, and the only way that you can get out of it is by cutting physician comp, then you're in a very tight position that will most likely result in provider losses. But the interesting thing is most organizations that we come into that feel like their biggest challenge or their only challenge is provider comp, frequently that is not the case. It's just obviously the most noticeable line item on the expense statement when we start looking at provider cost. So let's bring back our sample employed network. So we looked at, we saw that they were about a 25th percentile revenue per work RVU organization and about a 37th percent expense per work RVU organization. When we layer that into our framework of looking at revenue per work RVU and expense per work RVU, what we want to do is move the organization to the right, because they're already up, they're already a low expense network, but we want to start increasing revenue while maintaining our low expense structure. What we don't really want to do is move. We definitely don't want to increase expenses without increasing revenue, and we ideally would not gain revenue by significantly increasing expenses. So what we're trying to do is as we evaluate the network, is figure out what initiatives have the highest ROI and can maximize revenue per work RVU while helping us maintain or only slowly increase our expense per work RVU. So that moves us into our subsidy reduction framework, which we basically have 5 big buckets of questions we recommend organizations ask themselves, and then have a number of influencing factors, which are reasonably comprehensive for what organizations need to focus on. Every organization may have one or two things that are either more or less of a priority for them. But the first question we ask is can we increase collections on existing volume? So this is, we do no more work. We do exactly what we're doing right now in terms of, in our example, work RVUs. How do we increase collections? And so that's things like commercial contract rates. That's making sure our fee schedule's up to date. That's improving our capture of payer mix without basically trading payer mix as opposed to capturing more incremental patients. The two biggest areas that are typically an issue in this box, one is revenue cycle effectiveness. So for everything we're doing, are we getting paid what we should be getting paid, and two, when we should be getting paid. And then coding and documentation is frequently an issue as well. Both for, obviously, if we have a subsidy issue, we would hope that the network is undercoding rather than overcoding. But frequently, we see organizations that are struggling with finances to be in an undercoding situation. The coding and documentation very reliant on 2 factors. One, adequate communication and education from the billing office and coding team back to practices and providers, and 2, provider compensation model, because providers tend to code and document in a manner that, not saying it's anyone individually, but as an aggregate, providers tend to code and document in a way that is correlated with their incentives from a compensation model. The second question we ask is, can we decrease expenses on existing volume? So this means we're doing no more volume. How do we take our expense structure down without impacting volume? So one way we do that is by looking at the mixture of physicians and advanced practitioners. We see wild variation market to market, even health system to health system, in ratios of physicians to advanced practitioners. A lot of that is history and culture. Some of that is compensation model. Some of that is supply and demand. But a lot of organizations that are struggling financially or struggling with losses that are higher than they'd like them to be generally have opportunity to take high physician to advanced practitioner ratios and move them. And you certainly won't do that over a 6-month period. But as you start to link that to things like medical staff development planning, and you're looking at your next 3-year plan, taking a provider plan that's 100% physicians, and we just add APPs whenever we feel like our physicians are busy, to maybe more of a process where our medical staff development plan says, for primary care, we need 30 FTEs of primary care. Maybe that's 15 physicians, and maybe that's 15 advanced practitioners. Or maybe it's 18 physicians and 15 advanced practitioners to fill 30 physician slots. But it's something that we look at achieving over time to get our provider costs down while being able to maintain access and maintain productivity. Staffing levels and utilization is less frequently an issue, though we find most networks are pretty good at managing staffing levels and utilization, but there definitely are some exceptions. So what we're talking about here is, do we have staffing that is in excess of what we need to maintain productivity? Staffing compensation, also generally less of an issue, but in some markets or in some organizations, it's an issue that's pretty well regulated by the market. We pay what we have to pay, but that's not always the case. Administrative overhead. So we talked earlier about getting the allocation of administrative overhead right for organizations that are um, where you're looking to manage a subsidy. One, evaluating how administrative overhead is allocated from the health system, and then two, looking at the administrative overhead that exists within your corporate shell for your employed network. Both of those represent opportunities for subsidy improvement if they're not adding an ROI. And then the last two, looking at practice overhead and practice consolidation. We're finding a lot of networks as they've kind of gotten through their growth phase and are working into their operational chaos phase, where we're figuring out we have all these providers now, what do we do with them? A lot of organizations are seeking efficiencies of scale by consolidating practices. Now, there's a lot of barriers to that, not the least of which is the culture of those practices, which your organization went out and acquired and said, nothing's, whenever you brought them on, 2008, 2010, said nothing's going to change. You can keep your name. They probably still have their names on them right now. So there's a lot of cultural challenges in addition to the operational challenges of reducing practice overhead and practice consolidation, but certainly something that organizations who are looking to manage losses should pursue or should evaluate. The third question we recommend is, can we generate more volumes with existing providers and staff? So this is, we keep our capacity, we keep our expense structure. How do we work more volume into the system? So one of those is patient retention strategies are a great place to invest. That goes back to our earlier comments of referral management within a system and having system capabilities to track patients across a care continuum and identify when they're leaving your health system network and where they're going to evaluate how we get those patients back in the system is a great investment for organizations with wanting to improve finances. Looking at provider schedules and scheduling templates, especially in an era where we've leading up to the COVID market, which we'll talk about in a minute, leading up to the COVID environment, we basically, some organizations that had telehealth capabilities pretty much kept those separate from their bricks and mortar practices. As we're moving into an environment where kind of the market expectation is going to be some virtual or telehealth access, we think more and more providers are going to be doing both. So how do we maximize a schedule that allows for providers to see patients in the office, providers to see patients virtually, and I guess I'll add a third one in here. How do we work new patients in, because there's going to be a lot of new patients seeking care or seeking access on a time frame that is maybe more expedited than normal because of a pent-up demand for care. So how do we maximize schedules, get them filled, and get them filled productively, particularly in an era where we're kind of changing how we're deploying our access strategy, which also leads back up to patient access, promoting better patient access, getting more patients into the same schedule, and getting them in even same day access. Is one way that we see organizations generating more volumes with existing staff. Fourth is just looking at things like lean, looking at things like practice operations. How do we make practice operations more efficient? Fifth is taking advantage of care management programs and making sure they get billed. We see a lot of organizations leaving money on the table or leaving opportunity for additional codes and documentation around care management that is basically just money that's not being taken advantage of. And sometimes that's some even organizations that have programs in place aren't doing that as efficiently as they should. Sixth is looking at service and procedure mix. So especially on the specialty side, what are our providers doing? And for what we're paying and what we're subsidizing, is their procedure mix where we want it to be? Are they working at too low of an acuity level? That is sometimes, though not often, a concern. And then last is top of license provider utilization, which really links back to provider mix and advanced practitioners. But does our care model allow for both the physician and our advanced practitioners and our clinical staff to all be used at top of license? And so a great example of top of license provider utilization is just even think about a cardiology practice. How are we utilizing our PAs within a cardiology practice when we have patients, of the 50% of patients that have routine care, routine checkups, and probably don't even need to be in the office. Are those being seen by the physician, or are those being pushed down to the advanced practitioner? Is the physician focusing on, multi-chronic patients, or are they taking that kind of routine care? So there's a lot there. What we generally find is there's a lot of opportunity for improvement in that space, which relates back to how well do we use advanced practitioners, and then how well do we promote access. So all these things are tied together. The question we often recommend clients ask, and that we've seen not a ton of tolerance for historically, but we suspect there'll be more tolerance for going forward, is should we be actively divesting providers or practices? And we've always couched this in two criteria. One, employed networks. There are very few markets that are just now moving to employment. Most markets, the employment mix kind of shifted over the last 10 to 15 years, which means that our employed network's been built over the last 10 to 15 years, which in a lot of organizations means that network's been built across 5 strategic plans. That network's been built across 5 to 7 medical staff development plans. That employed group has probably rotated through multiple high-level executives in the health system leaving. And what we find is a lot of physician networks just get bigger and they don't get smaller, because we don't want to deal with we don't want to disrupt the patient physician dynamic by divesting practices, and two, it's obviously a political challenge to divest providers or practices. But we've always historically said that that's something that should be frequently reevaluated, especially as part of your strategic plan or med staff development process. In a post-COVID era where we're reevaluating fundamentally how do we deliver care, what specialties are truly important, and most especially for this presentation, how do we manage the subsidy of our network? This is the time to really take a hard look at what are we subsidizing and why are we subsidizing it? And does that fit within our mission, our vision, and our strategic plan? And in that case, if we find practices or providers that don't, this is a really good time to reevaluate that. One other reason to maybe evaluate divestiture, even if it's a provider that we want to keep in our community and seeing our patients, is we've seen a lot more FQHC activity in a lot of markets. And so as payer mix devolves, which it almost certainly will in every market over the next 12 to 18 to 24 months, due to 31 million people being employed as of this morning, being aggressive in those relationships and shifting providers that we currently subsidize to cost-based reimbursement makes a lot of sense, with the caveats of culture and alignment maybe being something that suffers as a result. And then the last question we ask is, being able to identify all of these challenges or what the opportunity is in all these areas is great, but what do we do with it? And as I said earlier, some of these are things that can really be addressed on the administrative side. Revenue cycle is a great example of what can largely be addressed on the administrative side. Staffing levels and utilization, that's something that can generally be addressed on the administrative side, but of course, with provider pushback. So there's a number of these that can be taken care of administratively. But as we start thinking about required organizational capabilities to make these adjustments, a lot of these require 5 common elements. One is we have to have the providers aligned from a compensation perspective. So if we're trying to change any of the things, anything in the first 3 buckets, are we asking our providers to do something differently than what we're trying to change? And frequently we find that is the case. We see a lot of organizations struggling with, I'll give an example of organizations on revenue minus expense models trying to execute strategic growth initiatives. Well, physicians who are on revenue minus expense models don't really have a desire for the network to grow because that directly cannibalizes their volume. Same thing to a lesser extent with work RVU models. So if we're talking about things like growth, do we have our providers aligned? Does our model align for that? If we're looking at managing, if we're looking at going back to provider mix and top of license provider utilization, if we're looking to create a more care team oriented practice model, does our provider compensation model account for that, or are we basically penalizing our physicians for passing patients off to their advanced practitioners? Do we have more of a team-based model that might be more appropriate for that? So compensation model plays a big factor in a lot of these influencing factors. The second is a shared vision and culture. So do we have a vision of how physicians and administration, do we have a vision of what we're trying to accomplish and why we need to change things in the first four buckets and how it fits into our vision to do so? Because that's frequently a challenge. If we have a bunch of independent, people are fond of saying we have a bunch of independent physicians that all get a paycheck from the same place, meaning we have an employed network, but the physicians don't really feel employed or act like they're employed. If we don't have some sort of common vision or common culture, a lot of these things in these first four buckets are going to really be attacks on that group, because we're not changing things in the context of our vision, and we don't have a common culture and that we're working towards a common goal. Third is having management infrastructure in place to actually make changes. So the organizations that we find struggle the most with subsidies or losses on a physician network are the ones that are historically underinvested in management infrastructure as opposed to overinvested. We have too few people trying to manage too many things. When that happens, processes either don't get put into place at all or get broken quickly. And the few people that we do have running around trying to fight fires day to day are not able to focus on anything that's big picture and moving the organization forward. So having the right infrastructure in place is a key to being able to influence your subsidy performance at all. Fourth is data reporting and communication. So a lot of these elements in these first four buckets are not something that we fix today and are fixed tomorrow. They're processes we put into place and we change over time. A lot of organizations that struggle with subsidies and losses are ones that aren't able to aggregate great data about their network, are not able to make that data meaningful, and are not able to communicate to their staff, to their leadership, and to their providers what direction the data is going and how it relates back to our goal of improving physician network losses or subsidy. And then the fifth capability is just physician leadership and engagement. So I think one of the initial things I said was when we started this webinar was having engaged physician leaders is a requirement to addressing a lot of the components that are listed in the first four boxes on this chart. And so if we don't have a physician leadership structure that is prepared to help us evaluate these things, that can provide some of the inertia for once they get working on them and talking to other providers and basically building a coalition of providers to help us with these things. If we don't have that, it's really hard to push that through from just a purely administrative perspective. So these are the things that even as we're evaluating how do we improve network losses, we should be evaluating how do we build these things into our organizational capabilities so that as we identify opportunities, we can make adjustments. So we'll take the next couple minutes to drill down on a few of these things and really talk about how we see these elements being impacted by the last 8 weeks or so of the COVID pandemic. The first thing that we've been pointing out to clients is, and I think everyone's probably experiencing, is we have a lot of disrupted workflows. We have providers out of office, we have staff out of office. We have different ways we're deploying providers and staff. We have providers and staff coding and documenting things they haven't documented and coded before. We see revenue cycle being at risk of being severely disrupted for a while. And so that's something that we recommend organizations actively work to get their arms around right now. Two, relatedly, as I just said, coding and documentation, education, and support is going to be critical going forward, especially through these next 6 to 12 months, because this last 8 week period again has been so disruptive and has entailed so much change, that without evolving our education and support resources, we're going to be at risk of coding and documentation going a little haywire. And then we recommend most organizations generally keep a good take a good look at their payer mix by practice and monitor changes. Um, our organization is maybe recommending organizations be a little more proactive in thinking about their payer policy mix, what you're willing to take on from a self-pay, Medicaid, uh, maybe Medicare population, by practice, and making sure that we have appropriate thresholds set, because one thing we think is certainly a risk in a lot of markets is disruption of commercial, and well-paying Medicare volume, and having those payer classes downgrade. And so that's something that is something that should be monitored already, but something that should be a particular focus, over the next 6, 12, 18 months. From the perspective of decreasing expenses on current volume, from a staffing perspective, I think one of the questions we're getting asked and we're working with clients to answer is what's the right mix? How do we find the right balance between making sure our practice is financially sustainable and we're not choking off volume, while at the same time making sure that our levels of staffing in our practices are consistent with a volume that's probably not all the way back there, and are within the bounds of what we're able to financially tolerate or what we view as sustainable. As for all the reasons we talked about earlier, we view networks that haven't historically utilized advanced practice providers. We view them as being at a disadvantage in the current market. But the good news is that this is the best time to correct it, and it's the best time to get those APPs built into your medical staff development plan, and start aggressively thinking about how do we shift that mix and how do we build an appropriate care model, that takes advantage of advanced practitioners and at least gives us the view of how do we evolve, our provider cost per FTE or per work RVU, how do we evolve that down over time? And then we think, though certainly it'll be, maybe a challenge in the current environment as we're trying to ramp back up, we expect that there will be a lot of looks at practice consolidation, activities, to create efficiencies of scale and push down costs. But noting here that that'll be a pretty disruptive effort, as providers are trying to rebuild volumes post-COVID. So that may not be a 3-month activity. That may be a 2021 activity, recognizing that that's probably an area that we need to address going forward. In terms of generating more volume within the existing cost structure, as we noted earlier, practice operations and scheduling probably shouldn't be going back to status quo, shouldn't be going back to February 2020. How we operate the practice, who's in the practice, how patients get scheduled, how providers' days structured, all represent massive opportunities for revision, all with the goal of promoting efficiency and patient access. Again, we think monitoring patient retention, needs to evolve, being out of only EMR focused. So what we see is a lot of employed networks utilizing Epic or Cerner, tracking whether patients that were referred from a practice, one, stayed in network, and two, did they actually go where they were referred to. We think in a post-COVID market, organizations need to take a broader view, maybe take a claims data focused view, and start tracking patients across the care continuum. So looking at the patients that interact, say, with your primary care network, where are they going? How are they seeking care? Because we really expect that the traditional patient provider relationships are going to be disrupted, over the next 6 to 12 months. And then finally, just for organizations that are looking for opportunities to improve, revenue within their existing cost structure, we'll again reemphasize that care management, especially as we're bringing patients back into the practices that have maybe missed a few routine appointments, getting them into transitional care, chronic care management, making sure those things are taken advantage of. That certainly needs to be maximized if we're looking to reduce subsidy. Fourth, under divestiture considerations, we're going to emphasize this a little bit here in the webinar over the next two slides. We really think this is the time to ask hard questions about practice divestiture. Depending on, your mileage may vary, but depending on the severity of your financial situation, we'd recommend, putting together some sort of rubric, and this is the one we use, to prioritize practices in terms of, one, going forward, is that practice is that practice or provider a good cultural fit within our organization? Two, what's the financial performance of that practice, and how much is it positive or negative for the health system and for the employed network? Three, what's the overall productivity of the practice and the providers? And then four, what's the strategic relevance? So maybe leaving mission out for a second. What's the strategic relevance of that practice? Because if we're looking to prioritize on finances, those are the four things that are probably the most important to us. We're very big on culture, obviously. And then we're already seeing it, but we'll again reemphasize, this is the time for heavily thinking about what FQHC resources or other similar organizations are available within your market, that transitioning practices to might make sense in terms of a win-win on helping those practices see a wider range of payer class patients and providing good access for our community, while at the same time minimizing subsidies for a health system. And slide 21 kind of reemphasizes why we think divesting practices is probably a strategy worth evaluating, not necessarily a strategy worth acting on at the moment, but certainly something we recommend evaluating. And again, that's because over the last 10 to 15 years, we've had a lot more serendipitous employment than we've had strategic employment, especially through the early growth phases of most employed networks. What we're seeing now as we go health system to health system, there's always a handful of practices that are that question mark of why are they here? What are they doing for us? Why do we have them employed other than because we employed them at some point previous to us asking the question? And our general view as it relates to divestiture is, the long-term health of an employed network might be disproportionately impacted by providers or practices that don't fit within the current vision or culture. So that's not only that maybe their practices aren't financially sound or that they're not productive, but that they tend to drag down they tend to drag down the culture, they tend to drag down the leadership structure. So if we don't have good fits right now who may even be, adequate from a financial performance perspective, this might be the time, as we're thinking through our divestiture strategy, to think about whether those practices and or providers are the right fit. In terms of the organizational capabilities, things that are impacted by COVID from our perspective, one, again, we'll emphasize every organization needs to be taking a look at its org chart and not just who's in those roles and what roles exist, but what does our infrastructure from a management perspective need to look like going forward? And that's with two big caveats. One, what does our care delivery look like going forward, and how disrupted do we think our traditional is going to be from virtual and telehealth? And then two, what do we think what's the rest of our strategy around financial sustainability, and what can we support from a management infrastructure perspective in order to maximize productivity and maximize efficiency? Two, we talked a lot about compensation models earlier. The thing we're most concerned about from a compensation model perspective is we really expect, as things get back to normal, but the threat of the pandemic hangs around for the next, hopefully 6, but more likely 18 months. We expect to see a lot of provider pushback on incentive models that are pure productivity, whether those be revenue minus expense, pure work RVU models or work RVU models with a base that tend to that is set low enough to where productivity is basically the only goal. We expect compensation models. We expect physicians will force that conversation. So it's probably a good time to be prepared for what is our organizational thinking on the compensation model that best fits with our future vision of the network, because this is probably a time where we're going to have that conversation in a 2020 or early 2021 timeframe. And then finally, with all the disruption, if your organization hasn't developed a shared vision that kind of defines where we're working towards, why we have the employed network, what the mutual accountabilities of administration and physicians and providers are to each other. If we don't have that in place, it's the time to get it in place. And if we have it in place and we've been working off of it, now's the time to evaluate it and potentially reset it, because the disruption we're seeing to culture across most networks over the last 8 weeks has been pretty significant. And we think now's the time. It's maybe a little less financially focused, but it does build into one of the capabilities of being able to affect your finances. Having a vision of us all working together and working towards a goal puts us in the right mindset to be able to tackle subsidy reduction activities. I mentioned earlier we did a strategic implication survey on COVID-19. One of the questions we asked was, will we need to make changes to our employed group infrastructure as a result of COVID-19? We saw more than half of our respondents agreeing favorably. So that's just a little more data to say, if you're thinking about this, you're not on your own. A lot of organizations are reevaluating what does our infrastructure look like in the wake of COVID. And then following up on the provider compensation comments, one, we asked, do you anticipate or have you made any short-term changes? So what we saw from a majority of organizations were that they did not make compensation model changes for providers through the last 8 weeks, while 30% reduced provider compensation. But the interesting point was, do you anticipate needing to make permanent changes to provider compensation? Where 38% said no, we'll maintain the same models. 34% said maybe. So 72% not thinking that is an issue. That's something we actually fundamentally disagree with, because we think that while it's hard to wrap your head around that right now as a priority as we're reopening and getting back to speed, it's going to be a priority for the providers once they get back up to speed. Because I think everyone views their compensation at being at risk, and maybe recognizing that it's not completely aligned with what we're asking providers to do going forward. So in summary, wrapping up, and we're hitting time, one, we expect health systems to have an intense focus on network subsidies, particularly over the next 6 to 12 months as we're dealing with the financial impact of COVID. Two, employed networks can expect to have a difficult time moving past that conversation on finances as we start dealing with the first bullet here. So we can expect financial subsidy conversations to start coming up more and more, which puts us back in that operational chaos mindset, which really prevents the health system from executing its employed physician network strategy. Three, having appropriate expectations of how we reduce employed physician network losses is from our view, is the key. So not only have we identified what we can do, but what is our expectation organizationally, and does that match from a board and executive perspective and a physician network perspective? Fourth, as you saw from our subsidy reduction opportunity chart, we really think you have to look comprehensively. It can't just be an expense discussion. We have to look at both revenue and expense and be willing to question everything across the organization. But five, one key point here, we really think, as we noted, and there are some COVID specific dynamics that we need to manage as physician network people. But the fundamental management philosophy of high performing physician networks has not changed. So all the things that got you into your current environment, for all the reasons you think your current network's running well, the fundamentals haven't changed, just a bit of the application has. and really this new focus on losses that we think organizations are going to incur over the next 6 to 12 months. It doesn't change the fundamentals, it just changes the conversation a little bit. So with that, let me remind everyone that we were having, at least during the pandemic, we're having webinars every Thursday, so feel free to join any of these complimentary webinars. They are all available at our website, hsgadvisors.com. We have supplementary resources on our website, particularly under COVID-19 updates, so any content related to how organizations are managing the pandemic or employed physician network considerations are available under COVID-19 updates, along with our general views on employed physician networks and health systems across the country. We have a specific network article around cutting losses that was published in MGMA and is available at the link below. So with that, we'll look to see if we have any questions. Actually, I guess we're at time. So we'll follow up with any questions that were asked, not to keep everybody here. We'll follow up with any questions that were asked by email. If you have any questions that you didn't submit but want to talk to us about, our contact information is on the screen. And we thank everybody for their time. And we'll look forward to answering any questions you have by email. Thank you.